True Code, and we are very pleased to present to you part of our educational series. Today we're presenting Essential Tools for ICD-10. Our presenter today will be Karen Scott. Karen is a credentialed HIM professional. She is also an AHIMA-approved ICD-10 trainer. We're very excited to have Karen doing this presentation for you all today. I think you'll find it very informative. Just a housekeeping note before we get started. All panelists, due to the number of folks we have on, are on mute. If you have questions as we go throughout the presentation, which will take approximately an hour, please post your questions in the chat box. We will have a Q&A session, time permitting, at the end. And if we do not get to your question here today, we will certainly address it in an email and get back to you in the next day or so. So again, we're very excited to present Essential Tools for ICD-10. And I'd like to turn it over to Karen Scott.
Thank you, Todd. Hello, everyone, and welcome to our sessions today. I hope you are having warm weather wherever you are and not buried in too much snow throughout the country. It's my pleasure today, on behalf of True Code, to talk about some of the different areas and getting us ready for ICD-10. It does look, I know that there was a hearing this morning on Capitol Hill to talk about ICD-10 and to see if we're ready for that or not. So I expect some very interesting discussion from that, but we do now believe that we are going to go forward with ICD-10 effective October 1st of this year. So we wanted to just have some time to talk to you about some of the different areas. So what we're going to be talking about today, we are going to talk about some of the different areas in coding for ICD-10. Probably one of the most important things we need to do to get ready for ICD-10 is look at the documentation issues within your facility. That's whether you're a hospital or physician practice, whatever type of facility you work in. I think it's very, very important. We're going to spend a lot of our time on ICD-10 CM, but also a little bit on ICD-10 PCS. We're going to talk about gap analysis, look at some areas of concern in both diagnosis and procedure coding, and then talk as we go through about some different tools that can assist you in the transition to ICD-10. And then at the very end, we will talk a little bit about some tips to decrease your productivity decline. We do know that there's a projection of anywhere from 50 to 60% of a decrease in productivity, and this is a really good time to stop and think about all the different tools that you're currently using or those that you're thinking about using and how those can benefit you as we get ready for ICD-10. So let's start by talking about the gap analysis. The gap analysis is really, to me, one of the places of where to begin. I know sometimes getting ready for something this magnitude, it's hard to know where do I even start. There's just so much to do. Plus, you can't just stop everything else and stop and just go on totally on ICD-10. You have to deal with your regular day-to-day business. So one of the things that we recommend is that you start now on your gap analysis. The easiest way to do that is to start by identifying your top 10. Now when we say top 10, kind of like the David Letterman show, it's an easy number for us to look at. The top 10 we're looking at here is the most frequent services. Now that's not necessarily the most expensive services or the most problematic services. You want to start with your most frequent services, because if you can identify problems in the top 10, then that can help you as you address those. That's going to help you go a long way toward getting your facilities ready and doing everything you can to make sure that we don't have that huge productivity decline. Now, if you're with a hospital today, I'd recommend that you start with your top 10 medical DRGs and top 10 surgical DRGs. And for your outpatient, typically you're going to look at your top 10 outpatient surgery diagnoses and also those in the emergency department. That's a good way to start there. If you work with the clinics or professional fee services, you want to go with the top 10 diagnoses or the top 10 reason for visits. That's a good way to start of where do I even begin this. Now from there, you want to go in and compare. What you would want to do is review about 10 charts in each category. So if you're in a hospital and you pick the top 10 medical DRGs and the top 10 surgical DRGs, that would actually give you about 200 charts to look at there. I know that seems like a lot, but really looking at 10 in each area, that is going to really be able to help you be able to see if there's a pattern. And even in 10 charts, again, when you look at it that way, 10 charts is not seem like very much, but really you can find out some information. You can see if there's a pattern developing. So to pick your top 10 diagnoses from each of those top 10, get 10 charts, randomly select 10 charts with that diagnosis, and then start reviewing those. Again, same thing with ICD-10 PCS. Take your top 10 surgical DRGs or your top 10 procedures if you're an orthopedic office for whatever, or whatever you may be, and look at those as well. Now, as you're doing this, what you want to do is to start their dual coding. Now, dual coding takes on a lot of different forms, and people use this a lot. But basically, when I'm talking about dual coding, I'm saying code that chart in ICD-9, then code it again in ICD-10, and look to see if there are any documentation issues to make sure that we're ready for ICD-10. So basically, you might find that on 9 out of those 10 of those diagnoses, that pretty much all the documentation is there that's going to be required, and then you might find that 1 or 2 areas do require additional information. One of the nice things about ICD-10-CM is that it does follow the same patterns and process as ICD-9. So if you can code in ICD-9, then you can code in ICD-10 as well. All right, now let's move on with the next bit of information, and that is from there you want to compare the documentation, as I mentioned, and then what you also want to do is provide feedback and education to the different stakeholders. You want to talk to HIM, you want to talk to your coding professionals, your CDI or your clinical documentation improvement, and also your physician advisors, and look to see the best way to address that information and how do we get that in the medical record. And I'll talk about some of that as we go through today. And I think it's very important to create detailed reports and plans. How are we going to address that? Plans for training, and also assigning responsibility. Everybody's very, very busy as we're going through this information and as we're trying to get ready for ICD-10, and so it's very important that we do make sure that we do assign responsibility. And also, I like dates, because if you're like me, I'm pretty busy, and so if you tell me I don't need that for a couple of weeks, then it may go off my plate for a couple of weeks. If you say this is critical and I've got to have it by this date, then I'm going to put it on my calendar and I'm going to do everything I can to get you that information by that date. So I think that's important as well. Now let's move on to the next slide, and let's look at some of the areas of concern in diagnosis coding. And one of those areas of concern is going to be your fractures, and we're going to talk about the Castillo grading system. We're going to look just a little bit about seizures and epilepsy. We're going to talk about a new term such as the Glasgow Coma score, diabetes, asthma, myocardial infarct, or heart attack, and those are just some of the areas. Again, we can't go through everything today, but I just wanted to show you a couple of examples about as we've gone through and done some chart audits where we have found some problems and things for you to think about. Again, you know your staff, you know your doctors, you know your diagnoses better than we do, and we just wanted to give you some information in some of the areas that we're finding. Now, one other thing you want to remember in ICD-10 is that there are lots of combination codes. So you definitely want to be careful, because it may have taken you 2 or 3 codes in ICD-9, and now you only need 1 code in ICD-10. That's another reason why you want to be very careful with the GEMS mapping tool. The GEMS mapping tool can give you approximate between ICD-9 and ICD-10, but it does not take the place of an actual encoder or coding from the code books to make sure that you're really looking at all the chart documentation that is needed. Now, the next couple of slides, I've just taken some screenshots from my TrueCode encoder. I think it's really easy to use, and it does look very similar to a code book. So it's a very easy transition as we're learning ICD-10. If you're used to coding with the code book, TrueCode has lots of great tools embedded within it, but also it does have that code book feel. So it's really easy to use there. So I just wanted to give you an idea here. First off, you can see that I've got the ICD-10 codes, and I just added in some codes to simulate a patient, and you can see that some of the codes are just the same, even though the codes look very different. Some of the codes are exactly the same terminology-wise and structure-wise as they are in ICD-9-CM. So for example, here we have an ST elevation myocardial infarction. That's exactly the same terminology that we would have in ICD-9. However, now we can show exactly which artery is impacted by that particular patient's heart attack. So that's a little more specific than what we had in ICD-9. This J44.1, you can see for those of you on the inpatient side that the true code shows me that that's a CC. It does impact the DRG. Now that's helpful as we're getting ready to look at the impact, the financial impact of ICD-10, to looking at our DRGs, make sure we're getting paid appropriately. You can see that that is COPD with an acute exacerbation. Now that terminology is exactly the same as it was in ICD-9, and we look it up exactly the same way. The next code is I-25.729, and that is atherosclerotic autologous artery CABG with unspecified angina. So basically this is a coronary artery disease, and then this is the symptom of angina, of unstable angina, or unspecified angina here, unspecified angina, and it's a combination code. In ICD-9, that would have taken 2 different codes to fully identify the patient's condition. But in ICD-10, we only need the 1 code. The next one is one of our diabetes codes, E11.9, and I'm going to show you some of these examples in just a few minutes. But you can see that one is a type 2 diabetes without complication. So basically looks very similar at this point that our codes do right now. And then the last one is another one of our combination codes. K70.11 is alcoholic hepatitis with ascites. Instead of that being 2 codes like they are in ICD-9, it will only be 1 code necessary in ICD-10. So we have that combination code. And those are going to be really helpful. Remember, with codes, we're trying to paint a picture, tell the story about what's going on with the patient. And the new system is going to allow us to do that more specifically, but also sometimes with fewer codes. Now, as we go through, don't forget all of your things that you need to be reviewing. As you're learning ICD-10, you want to make sure that you're reviewing the new coding clinic articles that have been coming out. Now, we've started having coding clinic articles relating to ICD-10 since 2012, actually. So if you don't have a subscription to Coding Clinic, that's something that you can get as you're evaluating, like with encoders. That's something that can be a part of your encoder product. Or if you have to buy that paper, again, you want to look at the costing of that. But you definitely want to have access to the Coding Clinic articles because they are going to help us understand these codes a lot better as we're getting ready. We also want to make sure we're reviewing the official coding guidelines, and remember they have been updating those every year as well to make sure that we're coding correctly. And then you can see also with the way we have it in TrueCode is we have many of the coding advice listed out here. We've summarized some of the longer official coding guidelines, and we always tell you exactly where that comes from. So while you're coding, you can see that information. It's right there in front of you, and you can use that information as we go through. All right, so one of the areas that we might want to look at, and I'm going to give you an example here of what I would do with a gap analysis. Start with, again, your top 10. So let's say that one of our top 10 diagnoses is a fracture. So I want to go into ICD-9. I want to code the fracture in ICD-9, and basically it's the body part and then whether it's open or closed. And then I want to code it again in ICD-10. So when I look up a fracture of the femur, it's of the shaft of the femur, then I'm going to see that there are 2 different choices. Basically, you've got a traumatic fracture. You also have a pathologic fracture. And here we're looking at the traumatic fracture. And you can see there are lots of choices. There are a tremendous number of additional codes in this section of ICD-10-CM because of the fact that every single one of the types of fractures now have their own single code. Like in ICD-9, if you look at the bottom of my screen here, in ICD-9, a comminuted fracture was grouped together within a closed fracture. So there was no way to show that the patient had a comminuted fracture because there was a list that said if the patient had any of these types of fractures, comminuted, green stick, those kinds of things, then it was considered to be closed unless there was chart documentation to specify otherwise. So basically, we have had to kind of dummy down our documentation. We've had this great documentation. It said comminuted or spiral fracture in my pathology report or my x-ray report, but I was not able to really do anything with that because the code book limitations of ICD-9 did not allow me to show specifically the type of fracture. Now I can do that. So you can see, for example, the spiral fracture Just the spiral fracture of the shaft of the femur has 6 different choices. Is it displaced or non-displaced? And then is it at the right, left, or unspecified? Remember, that's another reason why we have a tremendous number of new codes in ICD-10, because they always have to have an unspecified code just in case there is no documentation to support it. Now, I hope that right versus left is something that's clearly documented in your medical record, but again, you never know. Sometimes things get left off, and so we do have the unspecified. So every time there was 1 code, now we have 3, right, left, and unspecified. Now, let's say that that was a displaced fracture, so let's move on down the line. And once we find out that it's a displaced fracture of the shaft of the right femur, then we have to code the 7th character. And the 7th character, and I'll just show you here, that's what the little plus sign means. Let me go back to that. The plus sign there means that there is a 7th character that I'm going to need to fully identify that patient's entire condition. When I click that little plus sign open, then I get the 7th character. And then I have to select whether it's an initial encounter, a subsequent encounter, or a sequela. So this is the first time an episode that we're seeing the patient. When they've come from the ER to the orthopedic surgeon's office, those are all initial encounter. But then if it's a subsequent, this basically means they're coming back. They're coming back after we treated them to have the cast changed, for example. And if they are coming back for a subsequent encounter, why are they coming back? Is it routine healing? Is it delayed healing? Is it a non-union? Or is it a malunion? And then a sequela is like a late effect. The fracture is not current, but because they had a fracture previous, there is still a leftover or a manifestation or a problem left over from that previously occurring fracture that is no longer acute. So the 7th character is required on all of our codes, and this is not something that we have had to code with ICD-9. So we start to look and make sure that the chart documentation clearly states whether it's an initial encounter, a subsequent, or this sequela. Now, let's say it's an initial encounter. Now we have 3 more choices. If it's the initial encounter, is it a closed fracture or an open fracture? And an open fracture is one where there is an opening between the bone and the outside of the body. Now remember, that does not necessarily mean that there is a bone jutting out of the body. It just means there's a communication. That can be a knife wound, a gunshot wound, or any like an embedded foreign body. Because if you have the bone that is exposed, that means that basically there's more chance for it to have an infection. And so that's why this becomes very, very important. So usually we can know closed versus open. But then we have this type 1, 2, or 3. Now this is something that's brand new. This is not anything that we've ever had to classify according to ICD-9 before. So this is typically, as you're going through your gap analysis, this is typically where you will find problems here because of the fact that we don't collect this. So then we have to figure out where do we get that, what is it, and then where do we get that from. So let's go a little bit further. Now, I just wanted to show you, again, here's just another character, again, showing you the 7th character here. But I wanted to show you that, again, with all of the official coding guidelines that talks to us about what we should be doing, again, you can see on my screen we have them right next to the codes themselves. And so it talks about the open fracture designations, and it says it's based on the Castillo open fracture classification, type 1, 2, or 3. And then also down here in the official coding guidelines, we've also put that over here as well to remind us that if the doctor does not indicate if it's open or closed, we have a default to closed. And if the doctor does not indicate whether it's displaced or not displaced, we're going to code that to displaced. So again, the official coding guidelines that we need to be coding and using while we're actually going through the codes and learning the codes, we need to make sure that they're handy for us to have right when we're coding, so that we can make sure that we are coding correctly. A lot of the rules have not changed, but some of them have. Sometimes as we have new documentation requirements, we need more information or a way to have a default. So this allows us to have that. So these are just, again, all of the official coding guidelines spelled out here and open for you here while you're coding. Now also, because I've got that Castillo classification in blue, that actually is a hyperlink. So let me go on and show you what that looks like. This is a hyperlink that's available within the encoder. And you can just see here, these are the Castillo classification. So we just did found it on the internet and made a way for you to get to it. And you can see here's type 1, puncture wound of less than or equal to 1 centimeter with a minimal soft tissue injury, minimal wound contamination or muscle crushing. Type 2 is where the wound is greater than 1 centimeter, and there is some injury there. And then type 3, A, B, and C, extensive soft tissue damage. And then what else is going on? Bone exposure. And then down here you've got also an associated with an arterial injury requiring repair for limb salvage. So that you can tell is going to be the most serious because we're going to have to do everything we can to make sure that this bone is being saved. We may have to actually amputate that patient's arm or limb, whatever it might be. So now that we know what the Castillo classifications are, now we have to figure out what do we do with that information. So again, as we follow through this gap analysis, we code it in ICD-9, we coded in ICD-10. We followed the process through to make sure that we had all the chart documentation as required to be able to code these. We indicated here, found an area that we weren't real sure of, that we didn't have collected. We weren't capturing this information. We found out what that information is, and then we go back to our medical staff. Now, typically you'd start with your, maybe your staff. Maybe if you have a champion doctor or your chief of staff in orthopedics in this case, whoever you've identified. I usually don't go to all my doctors first because then there's lots of things going on and it gives them an opportunity to be mad at the whole system. And we don't want that. We want to make it as easy as possible, and we don't want anybody to be more frustrated because ICD-10 is a very important transition, and it tells a lot of information. Remember that we're all being profiled. Our doctors, our hospitals, all that profiling that's going on out there mostly is in part is reported because of codes. So if you're looking for the top 10 orthopedic surgeons in your area, a lot of that information comes from the codes that we've supported. Now, because those codes are limited in their features, we are actually not really given a good picture sometimes. We are not able to show the severity of illness. ICD-10 is going to allow us to do that. We should really be able to measure outcomes of what's going on with our patients because we have better data to be able to support that. So remember, codes are not just for reimbursement. They're for collecting data and be able to use information appropriately based on what's going on with our patients. So that's kind of the whole process of the gap analysis. Go through, code it, see what the problems are, see if you have any. You may not have any problems or identified issues. Once you find out what the issues are, then you go back to the appropriate people. You say, what do we do about this? Now, one of my facilities has taken this information, and we started talking about where we could get this information from. We were hoping at first, we said, gosh, wouldn't that be great if the radiologists could give us this information? Because usually they're pretty easy to get to. They document pretty well, and it's pretty easy to find that in the operative or in their X-ray report. So we talked to the radiologist, and they said, you know what, I don't see the wound. I can't tell you if it's 1 centimeter or more. I'm looking at an image on the film. I don't know anything about the actual wound itself. So, okay, they were not who we needed to go to. So then we started talking to our physicians and said, what can we do about this? How can we make sure that this is in the chart documentation? Now, in one of my facilities, we have decided to add a drop-down box into their EHR. So as the doctors are going through, let's say in the emergency department, and they're coding, they're documenting everything as they go through, they've selected that the patient has a fracture, and then we're going to add a drop-down box to that to say what type of fracture is it, open or closed, displaced, non-displaced, and then what is the Castillo classification if it is an open fracture. So they are already getting that underway. So pretty soon the doctors will have that information in their chart documentation so they can go ahead and start giving us that information now. Someone asked me not long ago, should I wait until ICD-10 or should I go ahead and do this now? My recommendation to you is go ahead and start now, because the little things we can do now, the things that we can get taken care of now to be able to get in the medical record and make it, take care of it, so to speak, then that's going to be less frustration for my doctors, because otherwise we're going to be querying them, questioning them every single day, and they're really going to get tired of seeing us or getting emails from us. And it's going to add to their frustration. But also by getting prepared and doing this now, that's also going to help my coding professionals to make sure that they are prepared and that they're not frustrated with being slowed down. Because when we talk about that productivity slowing us down, remember, it's not just the coders. It's not just training the coders. You can have the best trained coders in the world, but if they still have poor documentation or don't have what they need, then that could be a problem. Now, we were hoping that the electronic health record in general would be a great tool to help us with all of these things in healthcare. But what we're finding actually is that a lot of physicians are very, very frustrated with the electronic health records. They feel tied. They feel trapped to go in and just check box. instead of going through and actually typing things in or giving more narrative about the patient. They're just going down and picking a box, checking it, and moving on. And so it's really not doing what we wanted it to do. So you need to really pay close attention to how we're documenting in the electronic record and take steps now to help our physicians as we have time to do that. Okay, so let's go on and look at some other areas here. This one you can just see in epilepsy. I just wanted you to see as we go through the alphabetic index, you can see that there are more choices in epilepsy. Used to in ICD-9, there was just a couple of choices, and here we've got a lot of new terminology. And in fact, it says epilepsy with, like complex partial seizures, C, epilepsy localization related, symptomatic with complex partial seizures. That's a lot of information right there. Again, you need to be going through and doing your gap analysis. If this is one of your main diagnoses, what do we know about it? Does the doctor speak this kind of terminology? Or we can show this to our physicians. It says localization related. Doctor, what would you say instead of that? Is there other terms? And also notice up here, it talks about intractable epilepsy. And up here it tells me, what does that mean? These terms are equivalent to intractable. So if the doctor says any of these kind of terminology, including poorly controlled is equal to intractable. So when I'm coding it, if it says intractable and my doctor says poorly controlled, I don't have to question him. I don't have to query him. I say, okay, the code book tells me that's the same thing, and that's how I'm going to code it. So that should be helpful information. So watch through your code book. Again, I know there's a lot of information out there, but you can see how helpful that could be to be able to have this information available to you. And here's another one. This is the Glasgow Coma Scale, and this one is a brand new terminology. We couldn't even code this. We had no way to code this in ICD-9, and so we've got more information that we're able to collect in ICD-10. So you can see if they do give us the Glasgow Coma score, we have ways to code that. Here's one of my diabetes codes, and this one you can see I just put in diabetes type 1, and you can see it took me to the E10 code in our ICD-10 code book, and you can see this is another area where we have lots of combination codes. You can see here we have a type 1 diabetic with ketoacidosis, which basically is an uncontrolled diabetic without coma or with coma. Now that's a symptom. Now I know coma seems like a pretty large symptom, but it's still a symptom. It's still caused by something, so it's still usually coded in the symptoms chapter in our code book. However, because it is a very common side effect of having some of these types of diabetes, as we have more problems and more severity of our diabetics, this is going to be a combination code. So if they do not have a coma, I'm going to use the E10.10. If they do, I'm going to use that with the I10.11. And that's a bunch of information. That may have taken 2 to 3 codes in ICD-9 that only takes 1 code in ICD-10. And down here you can see that some of them are broken down even further. This one is type 1 diabetes with kidney complications, and that is type 1 diabetes with diabetic nephropathy. Notice that nowhere in this area does it say insulin dependent or non-insulin dependent, because that's no longer a good factor in dividing out our codes, because that caused a lot of miscoding in the past. Remember, the ICD system is a clinical coding system that is being used to group our patients into like areas. So it is very, very clinical. Remember, and this is something that's important to share with our doctors, remember that ICD-10 is put together by the World Health Organization, which is made up of physicians and other clinicians that have set up the system long before we used it to be able to pay based on the United States system. But again, it's a very good clinical system to divide these categories up to make sure that we're capturing information about the patients. Now here is our asthma codes. Again, here's another area where we see new terminology, mild versus moderate versus severe. You know, what does that mean and what are our doctors going to tell us? And then is it intermittent asthma or is it persistent asthma? And again, we need to do some work to try and make sure that we're clear on those. And then you have with acute exacerbation or status asthmaticus. And again, in the official coding guidelines, it tells you here, what does that mean? What is the clinical definition of an acute exacerbation? And so forth. So again, have those references and resources there handy for you while you're coding. It's going to make a difference. Now here is our heart attack codes. In the ICD-9 code book, heart attack codes or myocardial infarctions were considered to be acute for the first 8 weeks following the initial heart attack. Now remember, the ICD-9 system was set up and started being used back in the 1970s. Think about how medicine has changed since the 1970s. A patient came in with a heart attack in the 70s and 80s and even into the 90s, and we put them in bed, and they stayed in the bed for maybe 10, 15 days. You know, we kept them in the hospital a long time to make sure they were really healed. Over the time, we started looking at ways, was this really the best way to handle the patients and help them get ready to get back into their lives again. And so we found out that we could start doing cardiac rehab very early. We could start getting them up. We can do cardiac caths very early when they come into the cath lab when they first come into the hospital. And so we can take care of the blockage right away. So there's so many things that are different now. When the physicians were looking at making changes from ICD-9 to ICD-10, they said, you know what, really 8 weeks is really too long clinically to be considered an acute attack. We really feel like 4 weeks is really more appropriate based on today's medicine and the way that we treat patients today. So that's something that's changed. So if in ICD-9, if you had a secondary condition of a heart attack anywhere in the first 8 weeks, that might count as a CC. That might help you get a higher weighted reimbursement because it took longer for the patient to heal. However, in ICD-10, the duration is only 4 weeks. So if you had someone who was in the hospital later on, maybe 6 weeks out, you may have gotten a secondary condition that may help you where it would not count in ICD-10. So that may make a difference in your reimbursement. That's another reason why we should be doing these gap analysis now and looking at reimbursement to make sure that we can see what kinds of issues we're going to have and see if we're going to lose money or if it's going to be different in the future. Now, a lot of the other things here are exactly the same. Right now, we have a code for healed or old. It's 425 in ICD-9, and so in ICD-10, it's I-25.2. Excuse me, it's 412 in ICD-9 and I-25.2 in ICD-10. We also have some new terminology, like if they had a heart attack during cardiac surgery, we have a totally different code for a complication for that, and so forth. Here's what the code looks like if I go to my tabular part of my book. And for example, here is I-21.01, and it shows me in my code book that that is an MCC, so it tells me that that is going to be a major complication that is going to impact my reimbursement. And it shows me that it's specifically 2 of the anterior wall. We're already collecting that in ICD-9, but then it tells me involving what artery. Now, this is something I'm not collecting in ICD-9 that if I know it in ICD-10, I certainly can get a better code. But again, remember, we have other. So if we know that it's an MI of the anterior wall, but we don't know the artery, then we would use this I-21.09. Now, the only way they'll typically know that is if they've done a cardiac cath or some other type of surgery. So a lot of patients that come in with heart attacks, we're not going to have that level of documentation because they don't know that yet. And that's perfectly fine. Remember, that's why the ICD system is so very good, because it does allow us to be able to code what we know as specifically as we know, but we still have the non-specific codes out there. If that's all the information we have, then I certainly can still code it. And again, make sure you're reviewing your ICD-10 guidelines. And I'm showing you again in my true code chart here where it does have all the official coding guidelines here for you while you're actually coding. One last thing in ICD-9 before we move into ICD-10, and that's something else you want to look at, is you want to look for your edits. You want to look within your code books to see if there are additional codes that might need to be assigned. So here you can see here in True Code, it's got the little yellow triangle, and when I hovered over that triangle to see what my message was, it said, hey, don't forget, if that patient also has hypertension, you should also be coding it. And also, if the patient is status post-administration of a TPA in a different facility, make sure you code those as well. So you need to have some kind of guidance there that's going to assist you in making sure that you're not missing anything, that you're coding everything. Because again, remember, there are things that are new and different in ICD-10. Having the correct tools that are going to assist you there is very, very important. And then you can see here on this slide at the bottom of my screen, I do have the DRG information there. So as I'm collecting that information, as I'm coding that information and trying to make sure that I have all the information, and then when I want to see see if it's going to impact my facility. You can see as I'm coding that it's got the DRG down here, and it tells me the whether it's got a CC or an MCC, and it tells me the reimbursement for my facility based on the information we get from Medicare. So that's really helpful as far as planning. We can see that as well. Okay, so let's take a few minutes to talk about ICD-10 PCS. Now, ICD-10 PCS we know is very, very different. It was developed by the 3M Corporation as a part of their guidance with, well, basically CMS gave it, outsourced it to them. And they came up with a system. And so basically you've got the ICD-10 PCS system. It's very, very different. I think this is the area where people are probably going to struggle most with the switching to ICD-10, because this system makes it's a good system, but it doesn't look like what we've done in the past. Every single category, every single character has to have a different meaning. So basically, every code is going to have 7 characters, and you can see here on this slide that each character means something different. So as we're making the transition over to ICD-10, we have to know what those are, we have to know how to get those information, and there's a lot of definitions that we have to know. One of the big areas, reasons why we need to make the transition forward, and I always like to give you a little bit of ammunition if you have people go, this is dumb, why are we doing this? Because we are not able to tell the whole story. Now let me go here and show you. In ICD-9, for example, there is one code for suture of an artery, and that is 39.31. One code for suture of the artery, and that's it. And in ICD-10 PCS, there are over 180 codes. Why do we need that many codes? Well, because there are several different approaches. Did we have to make a cut into the patient? That makes a difference than if we're just able to go in from the outside, if it's an external fix, or if we go in through maybe a needle or a catheter. What if we go in with a scope and look around while we're in there? That's something that's different too. And then also there's over 60 different arteries in the body. And so we need to be able to show which one of those arteries, because that makes a difference in our skill level. Now remember that we're using these codes now to be able to pay for services, especially on the inpatient side. We're using these codes, using ICD-9 codes to be able to capture information about outcomes, to look for why patients have passed away. Did the hospital do something wrong? Report cards. There's so many things that we're doing with codes right now, and we're not really able to paint the whole picture because of the limitations in the code book. Now let me just stop for a minute and say that you're only going to use ICD-10 PCS for inpatient coding for the hospital only. If you're coding for outpatient, or if you're coding for the professional services of the physicians, then you want to make sure that you know that CPT is not going away. This is not replacing CPT or HCPCS coding. It's still being used. This is only going to be used for inpatients coded and billed by the hospital. All right, so this gives you an example of why this is important. First patient here lacerated their digital artery on the index finger, requiring suture of the digital artery. We have this code, 3931, suture of the artery. In ICD-10, again, I know it's going to look different, 03QC4ZZ, but it tells me a lot of information. It tells me the root operation is a repair, and it's at the right hand of the artery, and it says they took an open approach to do that. Now let's look at the next scenario, kind of the other extremity of this, or other extreme, not extremity, but extreme there. The patient is stabbed in the chest, lacerating his or her aorta, requiring an open chest procedure to suture the aorta. That's a pretty big deal. That it means this patient's in trauma, they're going to die, because that artery, the biggest artery in the body, the aorta, if it's open, that they can bleed out very, very quickly. That's hugely different than the first scenario. But due to the limitations in ICD-9, I'm still coding it exactly the same. I'm coding it to 39.31, suture of the artery. So that doesn't show me the difference between the severity of illness. It doesn't show me what my doctor had to do to save this patient's life. That's a problem. We're not able to capture the data that we need to be able to show what went on with this patient. You can see that in ICD-10 PCS is 02QW0ZZ, and that's a repair of the thoracic aorta open approach. So that gives me a lot of information here about what's going on. Those codes are different enough. Now, most of the time you will find that most information needed to be able to code ICD-10 PCS is already found in your chart documentation. Things like left and right, things like what are we doing repair versus an excision, the body parts, all of that typically is there. So there's a lot of information, even though these look different. You will find out in many of your cases you will have enough information to be able to code these, even though I know it looks a little scarier and we really worry about documentation. But that's why you need to be doing this gap analysis, so that you can look at this information and see. Okay? So let's go on and talk again. One of the things you have to do is memorize. You have to go through and not even memorize, but just make sure you know the information and the definitions of those 31 root operations that are grouped into what do they do, like they take out some or all of a body part, taking out solids, fluids, or gases, cutting or separation, and so forth. As you're learning those, then you start learning what those 31 root operations are: excisions, resections, detachment, and this is their character. So this means the third character in an ICD-10 PCS code. If it's an excision, it's going to be a B. If it's a resection, it's going to be a T. If it's taking out solids, fluids, or gases, if it's a drainage, that's going to be in the third character is going to be a 9. If it's an extirpation, which is one of my very favorite words, extirpation basically means they removed a foreign body. So I don't know why they didn't just say foreign body, but again, they're trying to make sure we didn't have any overlapping sets. So that's one of the things you want to remember with the system, even though it looks very different. They came up with definitions because we wanted to make sure if one doctor said repair and another doctor said repair, that we're comparing those together and that they are really repairs as opposed to something else. So, for example, here is the definition of the root operation: excision, cutting off, and then it gives you some examples. Now, within the code book, when you look up the code for, this is an excision, and you can see here, and again, I've got my true code opened up here, and it's got the first character is the medical and surgical system. It's got the urinary system, that's a T, and then there's my operation. The B is the excision. Now, what they've done in true code is they've given you the definition there, so you don't have to go look it up. It says right there, if I'm coding an excision, there's the definition. And then you see that we have the last part of our book is if you're coding this in a paper code book, you know you have columns and rows and tables. And that gets a little confusing because there's lots of things and, you know, there's lots of rows and sometimes the tables go on for a while. So basically you have to have some kind of a system to be able to pick out what is the body part, what is the approach, if there's a device, and then if there's any qualifiers. So you can see here, as I'm going through, I would assign that it's the body part, right kidney. I would go through and look at the approach. Again, those are definitions that I need to make sure I'm learning. Open versus percutaneous, for example. Sometimes there's a whole list of devices. Sometimes there's not. And then qualifier, in this case, we know from our review of ICD-10 PCS that if you do have a biopsy, it counts as a qualifier diagnostic. So this is a biopsy of the kidney. It is an open biopsy of the kidney. That's how we know, and that's the information we're given. And then we have this code here, 0TB00ZX, excision of right kidney, open approach diagnostic. So it makes it a little easier to understand it that way. Now let's go back to our fracture patient that we talked about earlier. Now remember, we had to code the fracture, and now we need to code the procedure. So basically with the procedure, doctor says they did a reduction of the fracture of the bone. Let's say, well, it's the femur. So we did a reduction. So we need to transition the reduction terminology into what is it in ICD-10. And it's going to be repositioning, moving to its normal location or other suitable location, all or a portion of a body part. So here's what we're going to do. We're going to go through our code book, and in the alphabetic index of our code book, I go in, I look under the main term of reduction, and you can see there, just using my encoder, I went under reduction, and under reduction, there's fracture. Now remember, I'm going to continue to look up in my ICD-10 PCS code book the terminology they're using today, because many times it's going to assist me in telling me where I need to be. So like in this case, it says, well, a reduction of a fracture, the terminology is that repositioning. Now this goes to remind us again about how important our resources are. You want to make sure that you have all your resources you need and that you have the tools you need to be able to answer these questions, to be able to get comfortable with the codes. So one thing that you need to have as a reference is you need to have the appendices from the ICD-10 PCS appendices. So this is one we've got here. I wanted to show you here. You go under the appendices, and you can go under definitions, And then under definitions, I'd want to go under the operations. I'm looking for the root operations. And then I'm going to find right here under those, there's repositioning. So I have this as one of my references, my resources. I have these appendices, and I can see there's the definition, there's the explanation, and then there's some examples, and there is my fracture reduction. So now by using those resources and using those tools, I am able to find that information, make sure I feel comfortable, and then go ahead and make sure I'm coding that correctly. So now I go in and I look under repositioning of the femur, and again you can see there's that definition of repositioning in my code book while I'm actually coding it. I pick out the body part here, and then I pick out the approach. And the approach may change what devices are used. So if it's an open approach, I have a different list of devices than if it's an external approach. And I'll show you that slide in just a minute. But here I picked that it's of the lower femur of the left side. I picked that it's the open approach according to my chart documentation. I picked that they did an internal fixation device, and then there's no other choices here. Sometimes there will only be one choice. Remember, every code has to have 7 characters, but this just shows me that if there is nothing else, it automatically picks that one for me. And so that's a real benefit of having this electronic here as well. Now here's the same thing, but this is if it's a repositioning, but it is a closed reduction. The approach, another definition I have to be familiar with, the approach in ICD-10 for a closed reduction is actually external. They're going in from the outside. They're not cutting into the patient. They're not going in with the scope or anything like that. So it's external. Now notice, because it's an external approach, I only have one choice here, no device. So my device choices is going to change depending on what the approach is. So that allows me to be able to get to the information very, very quickly. Now I will tell you from an auditor standpoint, if I had to tell you of all of the audits we have done, going through and picking what is the one area that we see missed most commonly in our gap analysis, and that is device. Because that's things that we normally don't think about. You know, we might not think about internal fixation device needing to be a separate information there. But it really, once we get past this initial phase of just, oh my gosh, it looks different, it's really a pretty good system, and we're going to be able to use this for many, many years to come. And again, remember, when we're looking at getting paid correctly and classifying outcomes, looking at what went on with our patient, what did we do, what happened to them once they left here, that's going to make all the difference in the world. Now here's another one. Remember, there is a big difference between repair. Remember, sometimes the doctors are going to continue to call the things what they call it now. So as coding professionals, you've got to make sure that you understand and can translate from what the doctor says into what the code book says. So let's say, for example, the doctor says they did a repair of the ligament, the repair of the knee ligament. So I went under the main term of repair, restoring to the extent possible body part to its normal anatomic structure and function. And I went under, I found there's the body part, the knee, and then I found the approach, and then there's no device or qualifier. And notice that that is 0MQP0ZZ. But we got to make sure that that repair is actually the right definition. So when I'm coding, when I'm doing my gap analysis, I always make kind of like a timeout. When I'm coding, when I've looked something up in the alphabetic index, and then I'm going to get into my tabular part of my book, then I always stop when I get to this screen, because I want to make sure I stop and say, is this the right root operation? Because if it's not, I'm in the wrong spot. Everything else might look exactly perfect, but if I'm in the wrong root operation, then I've got the wrong code, and I might get paid incorrectly, might be classified incorrectly, my profile might look off. So let's go a different way. What if instead of repair, they actually did a repositioning? It was out of its normal location, and they had to pop it back in place again, like it was dislocated. Well, so repositioning, moving to its normal location, all or portion of a body part, that is 0MSP0ZZ. So it looks very similar. The only difference in the last code that we just looked at and this one is this third character, OMS, versus the Q that we saw in the last one. So the root operation is the only thing that's different. Everything else is the same. That's a real danger. We have to be very, very careful. If you don't have that root operation right, everything else is going to look right, but it's not going to be. And that's also where you can use your not only in your gap analysis, but also use your GEMS mapping. where you can say, okay, what was this in ICD-9? Am I on the right track? Because sometimes these codes are very different, so we code it, but sometimes we can use the GEMS mapping to just make sure we're in the right location. I did that not long ago. We were trying to code someone who had a medical induction of labor, and I kept getting these codes in ICD-10 PCS that was something about administration of hormone, and I thought, well, that sounds sort of right, but I want to make sure, so I used my GEMS mapping tool to be able to map it out. I knew what the ICD-9 code was, so then I coded it that way instead, and I saw, yes, I was in the right location. So it gave me one extra bit of information that helped me feel comfortable with that chart assignment. So you've got to be really careful. Remember, your doctors are going to speak the lingo that they've always spoken. They're going to call it exactly the same thing. You know, so you look and you do these exercises like, what if they say they reattach the finger? What's the root operation? What's a heart transplant? What's a pedicle graft? What's a closed reduction of the fracture? And then go through and say, okay, a finger reattach, well, that's a reattachment. A heart transplant, fortunately, that's a transplant. That one's pretty easy. A pedicle grafting, well, if it's a flap, it's a transfer. So I may need to know more information about that. Is it really a graft, or is it a flap? Because that makes a difference in my root operation. And then, as we just saw, a closed reduction of a fracture is actually the repositioning. So make sure you're taking the time to go through and answer these kinds of things. Now, one other reference that you might want to have that is a good workbook. And this is one. This is actually the one that used to be the old Fay Brown book that we used to call it for years of coding with this. It's put out by the American Hospital Association. And this is one that is going to take you through both ICD-10 CM and ICD-10 PCS. This is actually part of the TrueCode package. It's included in there. So I just wanted to show you what that looks like. And this has got all the exercises in it. It's got examples in it. It helps you learn ICD-10. So those are some of the tools of the trade that are going to assist you in being able to code correctly. And they're all very important. Again, you want to make sure that you have all those accessible. Either, you know, if you've got everything paper, where's that all going to be? Are you going to have to buy workbooks for everybody, or is it going to be electronic in an encoder type of format? Now, the last thing I wanted to share with you today is just some other steps as you prepare for decreased productivity, things that you should be doing, and one of those is taking inventory of your coding professional knowledge base. I've been working a lot with doing anatomy. I'm actually going to Nashville, Tennessee tomorrow to do an advanced anatomy and medical terminology workshop. So look for those in your area. Look for making sure that we're coding, that we're doing the gap analysis, that we're doing dual coding. That's something that's very important. Everybody should start that. If you haven't already, you want to do at least some codes that you're some charts that you're coding in ICD-10 so you can get used to it the way it looks. You want to make sure that you're eliminating your coding backlogs. If you need to use outsourced personnel, prioritizing your medical records to be coded, making sure that you're having additional training to make sure you're improving your confidence levels and minimize any slowdowns. And then probably one of the biggest areas is your clinical documentation improvement program. Make sure you've got one. Make sure you're beefing it up. Make sure you have ways to discuss with our physicians while the patient's still in-house exactly what we need from them and help them to be able to give us the information that we need to be able to get everything coded correctly and get everybody paid correctly as well. All right, so that is all I have for you today. We do have about 5 minutes left, and the only question I have gotten so far is basic question on can you get a copy of the slides. And so we'll put that together as a PDF slideshow and send that out to you. We also will send you your CE certificate. So we'll put that together and get that out to everyone who registered for today. Are there any other questions for today? Let me see. I'm not seeing anything else in the chat area. All right. So, Todd, I'm going to turn it back over to you to thank you again for hosting this today, and I hope that you found it very helpful. Todd, back to you.
Great. Thank you, Karen. That was very informative. I want to thank everybody for your participation today. I also want to thank our partners. We have a number of CAC, CDI, and HIS system partners that sponsored the event today, and we want to thank all of them and hope that if you guys have needs as we approach ICD-10, you'll consider TrueCode and our partners and the various types of solutions that we can offer. This is also a list of some of the interface partners that we work with. Many of our hospitals probably have these systems in place, and these are all systems that TrueCode has experience working with. So again, I just want to thank you all for your time and hope you all have a great rest of your afternoon. Thank you.